In this video, we will review middle ear pressure homeostasis. Before we begin, consider the following questions. What is middle ear pressure homeostasis, and why is it necessary? What are the main mechanisms that regulate this? How do impairments in each mechanism present clinically? And what are the consequences of middle ear pressure dysfunction? And how does dysfunction in this system contribute to the development of acquired cholesteatoma? As we know, the middle ear serves to match the impedance between sound waves in the external auditory canal and the fluid-filled cochlea of the inner ear. This requires an air-filled middle ear space, which allows the ossicular chain to vibrate freely. Barometric pressure changes constantly. The middle ear must therefore be able to resist and respond to these fluctuations while maintaining a stable acoustic environment. Even in daily life, ambient barometric pressure may fluctuate by 100 to 400 decapascals due to weather patterns, lifts or changes in altitude, like on the underground or on high-speed trains. Middle ear pressure is regulated by three main mechanisms: the transmucosal gas exchange mechanism, the Eustachian tube, and the mastoid buffer. The middle ear and mastoid are lined by two different types of epithelium. The tubotympanic space, including the mesotympanum and hypertympanum, is lined by pseudostratified ciliated respiratory epithelium with goblet cells, just like the sinuses. Its role is primarily mucociliary clearance. The atticomastoid space, including the epitympanum, adytus, antrum, and mastoid air cells, is lined by flattened simple squamous epithelium optimized for gas exchange. In the mastoid, the honeycomb structure of the air cells increases the surface area available for gas exchange, much like alveoli in the lungs. Under normal conditions, gas exchange across this membrane allows minute-to-minute pressure regulation without the need for active Eustachian tube opening. Evolutionarily, humans didn't experience extreme pressure shifts like diving mammals or birds. This passive diffusion corrects for most low-grade moment-to-moment barometric fluctuations. But when inflammation occurs, like in otitis media, the mucosa becomes thickened, vascular congestion increases, and gas diffusion is impaired. Patients who have an impairment with this mechanism may report consistent ear pressure and fullness, which improves with Valsalva maneuver before shortly recurring a few minutes later. The Eustachian tube acts as a dynamic pressure release valve. It opens during swallowing or yawning to allow air to enter or exit the middle ear from the nasopharynx, equalizing large pressure gradients. The Eustachian tube is able to equilibrate larger fluctuations in pressure, such as those experienced when flying. It also plays an important role in enabling mucus clearance from the middle ear. If this valve fails, patients may be asymptomatic at rest, but experience sharp pressure or pain during flying, diving, or other pressure changes. This suggests an impaired Eustachian tube function, but preserved gas exchange capacity. Importantly, both mechanisms must work together, and for that to happen, the epitympanum and mesotympanum must be in anatomical continuity. There are three narrow channels that connect the two compartments: the tensorfold region, the anterior isthmus between the long process of the incus and the malleus handle, and the posterior isthmus between the long process of the incus and the scutum. When these are patent, gas exchange and pressure equilibration can occur throughout the entire middle ear cleft. When obstructed, such as in chronic inflammation or adhesions, the compartments become isolated, setting the stage for pressure imbalance and retraction. The mastoid air cell system acts as a pressure buffer, expanding the air volume of the middle ear system. According to Boyle's law, for a given amount of gas, a larger volume reduces the impact of pressure changes. This makes the mastoid a passive pressure buffer. But not all mastoids are equal. A well-pneumatized mastoid has greater air volume and more surface area for gas exchange, whereas a sclerotic mastoid, often seen in patients with chronic otitis media, has both a reduced volume and lower surface area, diminishing both buffer and gas exchange functions. This is why poor mastoid development is often associated with CSOM, retraction, or pressure-related disease. When the compartments are no longer in continuity due to webs, adhesions, or scarring, chronic negative pressure can develop in either space. If the Eustachian tube fails but the gas exchange mechanism is intact, patients may develop pars tensor retraction with a preserved epitympanum. If the atticomastoid space becomes isolated and its lining fails to compensate, Negative pressure draws in the pars flaccida, the most compliant part of the tympanic membrane. This results in a retraction pocket which traps keratinizing squamous epithelium. Over time, the pocket enlarges and disrupts the normal lateral epithelial migration. Keratin debris accumulates and becomes infected. This forms an acquired cholesteatoma, a destructive epidermal inclusion cyst that erodes bone, ossicle, and surrounding structures. Recognizing the interplay between pressure regulation, mucosal function, anatomy, and disease progression is essential in understanding middle ear pathophysiology. I hope you found this video to be useful. I'd be grateful for your feedback in the comment section below, and let us know what you'd like us to cover next.